we've all probably met before. I'm a GP and I work in Hammersmith and Fulham, and I'm the North West London clinical lead for cancer in primary care. I also lead on the non-site specific rapid diagnostic centre pathway for RM Partners, which is our Cancer Alliance. And I'm joined here by Baldeep, actually Baldeep, I'll let you introduce yourself.
Hello everyone, I'm Baldeep. I'm a GP in Hammersmith and Fulham, and I'm also the clinical lead for Hammersmith and Fulham in terms of cancer, and I'm also the clinical lead for the Rapid Diagnostic Centre at West Middlesex Hospital.
Thanks, Baldeep. So goes without saying that today our focus is on rapid diagnostic centres, and we're going to spend some time going through this today, which I'm sure you've all heard about in some shape or form. So just kind of a bit of housekeeping. Is it okay if we just ensure that everyone's muted to avoid any background noise? And if your videos are off, that'd be really helpful in order to just increase our bandwidth. And let's use the chat function as the main way to ask any questions. But if you've got something that you would like to highlight, please do raise your hand and we'll come to you. We will be recording the webinar, and all the slides and the recordings will be sent out by the training hubs and the primary care comms team. So I hope that's okay. And please do kind of raise any questions, because that's really helpful for us. And also, if you're thinking it, I'm sure other people are thinking it as well. And right at the end, as always, we will put the evaluation link in the chat box in the text function. And so it'd be really helpful for us if you could give us that feedback, because that really does help us shape our webinars moving forward. So thank you. Okay, so we've got the aims of the session up on the screen today. Just if you're here and not muted, do you mind just muting yourself, please? I think we've got Amisha. Sophie, do you think you could mute Amisha and Amir? Thank you.
I will do.
Thanks. Okay, right. So the aims of the session, we're going to be talking about the Rapid Diagnostic Centre model. We're going to talk a little bit about the context within the national framework, and also what we're doing within West London, obviously more specifically North West London. We're going to talk about the kinds of patients and what goes through the RDC, how does it work, what are the local RDCs, and a little bit about outcomes and data. And then at the end, we'll go through some case studies, which will hopefully bring it to life a little bit. Great. Okay. It's important to note, actually, on the last slide, that the RDCs are within our PCN DES for early cancer diagnosis. And so you'll remember the webinar that we did about the PCN DES. If you haven't seen it, please do go back and have a look at the recording. And part of the DES functionality, or what we need to be doing for 22-23, is increasing our use of our rapid diagnostic centres. So hopefully this will give you an idea of how to do that. Right, okay, and this is a little bit of a breakdown, as I've just said, so we'll crack on to the next slide. Thank you. Okay, so really we are, all of us, acutely aware of the need to reduce the time to diagnosing cancer within our patients. And we know that this is part of the long-term plan, the NHS long-term plan of the UK, and there is an aspiration to diagnose 75% of cancers within stage 1 or 2 by 2028. So clearly we are some way away from this, but there are certain benefits to patients being diagnosed earlier, and that's improved outcomes and improved prognosis of patients when we diagnose cancer. But not only this, but also that they'll have better experiences of their care, they'll have an improved quality of life, and they're less likely to experience morbidity from treatment if diagnosed earlier. So it's incredibly important that we focus on diagnosing cancer as early as possible. Next slide, please. And so it goes without saying, and it fits, that a delayed diagnosis confers a worse prognosis. And we can see here in the context of lung cancer that an advanced stage of diagnosis is related to kind of an increased mortality. You'll also see that within the UK, we measure up quite poorly compared to our counterparts elsewhere, within Europe and within the States and Canada, and when it comes to diagnosing cancer early, and particularly within this publication of thorax. Next slide, please. So a delay in diagnosis is related to lots of things. It's multifactorial, and sometimes and often it's due to the patient. Does the patient come to us? Do they present? Do they know about red flag symptoms, and are they aware of when to come to their GP or other healthcare professional within the community in order to flag some of these issues? Also, and how we access primary care. And we know in the wake of the pandemic and things moving forward, there are changes in the way that we practice within the community. Also in the way that we access secondary care. We know that we can send off 2-week wait pathways for site-specific concerns. And this also brings me down to symptoms, because symptoms is a key feature within this matrix. And in the next slide, this brings me to the concept of vague symptoms. Now, we all know these kind of patients that come to us. They don't come in that often, but they may come in and they may really worry you. So these are the kind of ones that may have quite significant weight loss, which we can't pin down why, an unintentional weight loss, fatigue, which doesn't add up, some non-specific abdominal pain if their fit is less than 10, or nausea, or you may just be worried about cancer. Now, it doesn't always mean that these particular symptoms indicate a specific type of cancer. They may suggest several cancers or other diseases. And we know that within our traditional way of practicing and within primary care, we've got tumour-specific pathways that these exist. So if I'm worried about a patient with a chronic cough, and hemoptysis and exertional dyspnea, I could send down a lung 2-week wait if they've got a chest x-ray that's worrying. Or if they've got PR bleeding or raised fit, I've got a colorectal pathway to go down. However, what do you do about these patients where you're worried about cancer, but you're not entirely sure which pathway to send them down? Traditionally, some of these patients may bounce between different teams, and they may actually end up having a later diagnostic interval, a longer diagnostic interval, and bring about some of the issues that I mentioned earlier on about delayed diagnosis and worse prognosis. Next slide, please. So we know, and there's good evidence to suggest, that those patients that present with vague symptoms, when we compare to those that present with traditional NG12 alarm symptoms, they are more likely to be diagnosed with a later stage of disease. They're more likely to end up in A&E and have a diagnosis there, which we know has a poorer prognosis and poorer outcome. And they actually make up a lower proportion of our 2-week wait referrals. And as I said, they'll have longer diagnostic intervals as well. Next slide, please. And so within this particular retrospective study, it kind of highlights some of these key issues. And this was published in the British Journal of Cancer back in 2014. So some time ago, the data was actually quite interesting. And actually, what this did was it took data from the general practice research database, and it analysed patients with one of about 15 cancers that were diagnosed in 2 time intervals, so 2001 to 2 and 2007 to 8. And really the primary aim of this study was to compare diagnostic intervals before and after the implementation of our NICE referral guidelines. However, there was a secondary aim here where they compared diagnostic intervals with those with different presenting symptoms. And what you can see here is that those that were presenting with vague symptoms or non-site specific symptoms that we've talked about already, they had about a 34-day longer diagnostic interval in both cohorts. So that was the 2001 to 2 and 2007 to 8. Next slide, please. And in the context of the rapid diagnostic centres, this Danish cancer study, this cross-sectional study, is actually quite well known. So it included patients that were referred to them within their RDC or their non-site specific pathway for about a year. And about 1,300 patients went through this particular study. What was quite interesting is that there was a strong association of a cancer diagnosis where there was a GP gut feeling of cancer, and the more common symptoms that patients presented with at this time were those with weight loss and fatigue. Next slide, please. So Baldip, I think I'm handing over to you now.
Thanks, Albs. So I was just going to run you through what rapid diagnostic centres actually are. So Albs has filled you in with the history of things, and then there is this cohort of patients that are just not picked up or don't fit neatly into a 2-week wait pathway. So we know that 1 in 2 of us will get cancer if we're born after the age of 1960, and cancer outcomes in England, as we know, are worse in any economically developed country. We have got strategies in place in terms of improving cancer prevention. We've got screening. We have campaigns that have gone out for patients to encourage timely presentations and not ignore vague symptoms. And then we also have the 2-week wait pathways that we can refer down. However, some patients just don't fit neatly down into a 2-week wait pathway, or they may activate several 2-week wait pathways at the same time. This is a clinic where somebody can be seen quickly. They have a generalist overview, and where it's for those that there's a clinical concern of an underlying cancer that just don't fit down a single 2-week wait pathway. And as Abs mentioned, it's modelled from the Danish study. So it's a non-site specific pathway. Other terms that we use for the RDCs are ADOC, which is the Chelsea West site, and then rapid diagnostic centres, rapid diagnostic centres as well. So next slide, please. So the service model itself and the ambition for it is to support earlier and faster cancer diagnoses by assessing the patient's symptoms holistically and providing a tailored pathway for clinically relevant diagnostic tests as well. And it's done as quickly as possible. The ambition is to create increased capacity through more efficient diagnostic pathways as well. So reducing the amount of unnecessary tests, reducing the amount of unnecessary appointments, and trying to organise all those appointments that are needed all on one visit if possible. It's to deliver a better personalised diagnostic experience for patients as well, and that's through a single point of contact, but also through organising all those diagnostics in one place, having a holistic approach to the symptoms and a generalist overview as well, tailored for the patient. To reduce unwarranted variation in referral for, access to, and in the reliability of relevant diagnostic tests. And this is across the board, and this is the national standards that are being set as well. So we regularly collect and input data, and we have KPIs that are reviewed every month, and we sit in line with the other rapid diagnostic centres across West London and nationally as well. And it's also an improvement. It's an improvement in terms of for staff, in terms of career roles and flexibility. It's created roles for GPs and clinical nurse specialists to work in different ways to the traditional ways and the traditional pathways as well. So it's definitely opened up a lot of opportunities and working in innovative ways. Next slide, please. So a non-site specific rapid diagnostic centre, it's a centre that provides better patient and GP experience as well, with faster access to relevant tests to diagnose or exclude a cancer in a cost-effective manner. It's a service designed specifically for GPs to refer into who might have non-specific but concerning symptoms and that gut feeling that Abs mentioned earlier on, of a new cancer where there is no alternative pathway for them. RDCs aim to see patients within 14 days and diagnose patients and communicate the diagnosis within 28 days. Just to be clear, it's not replacing any existing tumour pathways, it's for vague symptoms. So who is for an RDC? Patients need to be over the age of 18, have a clinical or radiological suspicion of cancer. Now, that clinical suspicion of cancer could be that gut feeling with a few abnormal blood tests. You just have that feeling that there's some concern there. Or radiological is when you've done a routine X-ray or an ultrasound and something abnormal has come up that looks suspicious. That can go down a rapid diagnostic centre pathway. It doesn't meet an alternative tumour-specific pathway, and patients need to be well enough to attend an outpatient appointment, and they must be told that, again with all your other tumour site pathways, when you're doing a 2-week wait referral, you are saying, I'm referring you in to rule out a cancer. It's the same with this one. They must be aware that there's a suspicion there of the cancer, which is why they're being referred to a rapid diagnostic centre. Next slide, please. So this is the implementation specification by NHS England for the RDC service model. So it's aiming for early identification of patients where cancer is possible, outreach and targeting health inequalities as well. A timely referral, so that's the GP part of it where the filter function tests are done, and I will go on to filter function tests and what we like on our filter function tests in a moment. Then there's a broad assessment of symptoms, and that's in clinic where first of all the referrals triaged by our clinical nurse specialists and all the relevant information is pulled and gathered. Then the patient is seen and then determine what diagnostics are needed needed and how quickly these need to be carried out. There are occasions where the clinical nurse specialist will triage the referral and decide a scan is needed before an outpatient appointment. So that triaging process is really key, which is why the filter function tests are really key at this point. And then coordinated testing, as I said, trying to get all the tests, CTs, endoscopies done all on the same day, so that it just reduces patients coming in and out of hospital, and it reduces the interval between investigation and diagnosis. And then communicating that to the patient, so the timely diagnosis of patient's symptoms, but also communicating it to the patient as well. Whether it's a cancer, if it's a cancer, it gets plugged into the multidisciplinary team that's relevant. If it's not a cancer, it's communicated to the patient. Often in our RDCs, we don't just stop at that, we do try and diagnose what could be possibly the cause of the symptoms, and then that's communicated to the patient or secondary care input if needed, and then letter to the GP and onward referral. And alongside all of this, the patient has a single point of contact. We have a pathway coordinator in each RDC that is the single point of contact for the patient. Next slide, please. So here at our acute diagnostic oncology clinic, which is the Chell West Mid site, we have our GP referral comes in. This is triaged by our excellent clinical nurse specialists. They triage the referral, they go through all the filter function tests, they work out how immediately investigations are needed, how quickly does the patient need to be seen in clinic, and then booked in and coordinated accordingly. They have their first visit, and that's where they'll be seen by a GP, where they have their generalist view, generalist assessment, and that's with the clinical nurse specialist too, and then investigations are organised. Thank you. So what does the workforce look like? So we have a clinical lead, which is often an oncologist in the RDCs, and they hold the actual responsibility for the RDC, and then the links and the networks for the NDT input. The GP who sits in the RDC is responsible for delivering these clinics within secondary care. So myself and ABS are based in AEC at Chelsea and Westminster and West Middlesex Hospital. We have an advanced nurse practitioner or clinical nurse specialist as well in our team, who following the RDC referral, they do that detailed triage, as I mentioned, and request imaging if needed, often pulling imaging from other sites as well, to ensure that we've got all the information there before we see the patient, or if patients need scan prior to being reviewed, that can be organised as well. We have a patient navigator that tracks our patients along the pathway, and we also now have SPIN GPs. We have 2 newly qualified GPs just to help advance their knowledge in cancer and support the RDC model going forwards into the future. Next slide, please. Abs.
Thanks, Baldi. That's really helpful. And I think, probably something to reinforce is, as Baldi just said, is we're not there to replace another pathway. If you are, as a GP, worried about a lung cancer, you should refer to the respiratory specialist. If you're worried about lower GI cancer, that should go to the lower GI team. But we're there for those where you're not entirely sure where the primary is, and the symptoms may be quite confusing, and you need a bit more of a kind of a holistic review, but you are still worried about cancer. And I think the primary aim of the RDC really is to diagnose or exclude cancer, as we've said. Kind of before I talk about SPIN GPs, I think we've got a couple of our team just to say hello here. I'll just quickly say we've got Sarah Bull here, who's the GP at Imperial. We've got Harjit Gill, who's our SPIN GP at West Middlesex. And we've got Maria, who's joined us from St George's as well, who's a GP SI over there at the RDC. So thank you guys for joining in, and they're useful contacts to know your local RDC GP if you do have any queries. So I said SPIN GPs, and I think you probably all know about the SPIN program, and so essentially this is trying to create a portfolio for newly qualified GPs where they have an interest in something a bit different. And so we have SPIN GPs that have started at the West Middlesex, Chelsea Westminster, St George's, and newly to start at Epsom St Heliers site, where they have a couple of sessions with us in the RDC. And so really the role there would be to learn about what happens in diagnostics, and help engage with our local surgeries, and engaging in kind of useful audits and research as well. And what we have considered is actually, in order to improve the sustainability of our workforce moving forward with more of a GP-led model at the centre, it's really helpful for us to have our SPIN GPs as part of our team. Great. Next slide, please.
Oh, Abs, I'm just going to introduce Rachel.
Oh, sorry, I forgot to.
Rachel's our amazing clinical nurse specialist based at Chelsea and Westminster site.
Great. Doesn't happen without Rachel. So Rachel's our lead CNS and also chairs the CNS forum as well for the Cancer Alliance. And so this kind of paints the picture of our geography within West London. And what we found is focusing within Northwest London that we've pretty much covered most of our geography. Now it's been a kind of a staggered release of the RDC programme. The national aim was for 100% cover by 23-24, but we tried to get things done a little bit quicker. And where we are currently is that we're open to all boroughs. And there are a handful of PCNs in Ealing who currently we're still working on, we're trying to build the workforce to be able to offer that service. Our borough lead within Ealing is Lindsay, who's here, and also will be sharing some comms and discussing with the PCN CDs in order to share some upcoming information about the rollout within the RDCs for that borough. So the live sites within Northwest London are Chelsea Westminster across West Middlesex and Chelsea site, and also we've got London Northwest as well. Imperial are due to open soon and will be out shortly. So there are a couple of questions actually that are coming in the chat box. So we've got Dr. Luther said, you've said England has one of the worst levels of early cancer diagnosis of developed countries. What are the other countries doing that we should be doing? I think that's a very complicated question, actually, and probably slightly outside the scope of the RDC thing, but maybe we can catch up offline and we can have a little bit of a chat about that, because I think we could talk for hours about this. And Imogen, where do Westminster patients go? Well, so Westminster patients are, I think you are within the Borough of Central, so correct me if I'm wrong, so the Central patients do refer to the Chelsea Westminster site. That will be live on ERS. And the last comment from Dr. Luther, we will have that coming up soon about the figures and data. Okay, so and this is just really a rough kind of overarching plan that from the Cancer Alliance about how our launch has been. Things have been a little bit delayed according to this, but generally speaking, we've had a trust-based rollout. And we've made sure that we review our KPI and referral data and evaluate the case long term, both from a clinical and economic point of view. And we've had ongoing development for our SPIN GPs and nursing team. And there is ongoing work on research and innovation, which sits, and we've done some interesting work with the Grail team as well, which we can touch on later. Next slide, please. Right, I think Baldi, back to you.
Yeah, thank you. So I was just going to go through the referral form and patient criteria with you. So each RDC has a very similar referral form. We've got ours up here, which is the ADOC referral form. As I said, London Northwest, the other sites have, it's very similar, and the filter function tests are similar too. So it's right on the front page, you'll find you refer it to us through ERS. I've got a slide on how you do that in a moment. And our referral criteria is there. So tick in the criteria, blood tests and a fit test within 4 weeks. And I'll press on that again in a moment. So that's the first page, and then it auto populates with all your filter function tests. We've got our phone number on there and our email address. So if you have any questions or any queries or whether you need to refer someone in or not, you can either email us or call us. Next slide, please. Thank you. And then there's a little bit more information, just if you can fill out as much information as you can, how long they've had the symptoms for, what are your concerns, how often have you seen, how many times have you seen them, because it's quite helpful to see how many times they're presenting to you, their performance status. What is often quite good is if you put a performance status in how they have been to how they've declined as well. That's really useful in terms of if a patient needs to go into MDT and treatment consideration in the future. And then there's our filter function test that auto populates when you fill out the form. Next slide, please. So what kind of referrals do we tend to get? The most common referral that we get in our rapid diagnostic centres are unintentional weight loss. It's probably the biggest referral that we've seen, haven't we, Abs? Anemia, raised inflammatory markers, just non-specific abdominal pain with a fit less than 10. Night sweats, sometimes night sweats alone don't fit through a haematology pathway. Fatigue as well, and abnormal radiology. As I said, sometimes we often get the, if there's any radiology that you've requested and it's come back looking a bit abnormal or it's been red flagged, we often see those patients too. Next slide, please. So this is how you refer to us on ERS. So we're under the 2-week wait pathway, and it's 2-week wait, non-specific symptoms, and then your closest one will come up. London Northwest is there at Northwick Park, but it's the same process when you're referring through ERS. Next slide, please. So filter function tests, I touched on this earlier on. They are really useful, especially in supporting us in making the process a lot more rapid for the patient and not delaying at any point in the pathway. It also helps with you deciding on whether you need to refer to us or not, and whether we are the most appropriate route or not. And it just leads to a better quality referral. There are only a few that we need. It's not an exhaustive list. As I said, and it also reduces duplication, so we're not repeating the same tests twice. And key thing is that we can have some pre-investigation testing done, especially kidney function, because if we do need to send somebody into the scanner to CT scan on the day, we then have a renal function there and we're ready to go. So it doesn't delay the pathway. We do recommend that the filter function tests are carried out in primary care where relevant, before you refer to the rapid diagnostic centre, because as I said, it makes the pathway so much smoother and easier and a little bit more enlightening for us. So core tests that we would like: chest x-ray. I appreciate sometimes that doesn't happen. A urine dip microscopy would be great. A fit test, and a fit test within the last 4 weeks. And that's important, because if you've got somebody with vague symptoms and their fit has come back positive, then you have a pathway for them. So that's why a fit test is important. And then all the other blood tests, they're not an exhaustive list, you can see them there. I just want to touch on tumour markers as well. Now, tumour markers, the only ones that we would like to be sent in with the referral are a CA125 for women and a PSA for men, and that's all. We don't need a CEA or a CA19-9. Those are more specific for when patients have been diagnosed with a cancer and then are on MDTs and then monitoring treatment as well. So the only tumour markers that we suggest doing for the RDC pathway are the CA125 and the PSA. And haematinics, if you can do them, that will be great. There's a list of additional tests there that are helpful. So if you do have some investigations on the patient's nose, please attach them in, because more information is more helpful for us in terms of organising diagnostics and investigations and moving forwards. Next slide, please. Perhaps I'm going to hand over to you.
Thanks. I might just add a couple of things, if that's all right, Baldi, and then just if we just go back a little bit to a couple of slides. So thank you, just here. So as Baldi said, these are incredibly important, and just on the aspect of serum tumour markers, it's sometimes can confuse the picture if we do the other tumour markers in a diagnostic in a diagnostic sense within the community. So would certainly encourage that we just stick to these two, and particularly in the context of vague symptoms, there's no evidence that doing a upper GI serum tumour markers are helpful at the diagnostic phase. Rachel's put in a comment in the chat box and would be to get the surgery bypass number, if we could put that in on the referral. And I think probably from the point, well, certainly from the point of the triage and making sure that the patient's in the right pathway, having a contact, a point of contact for us is really helpful. And so I think if that's one kind of key thing that we could have as well as a kind of a practice email that's checked regularly, that would be incredibly helpful. And maybe that's something that you can put into auto-populating your forms. Some of the feedback that sometimes we get, because it's a new pathway and patients are not entirely certain about why they're being referred to the service, and sometimes it can be a very difficult kind of position that we find ourselves in, talking about quite serious conversations, and sometimes patients then won't come to the appointment because they don't feel that it is serious enough, and rather than if they were sent down a suspected lung cancer pathway. So I guess it's important to try and reinforce that this is a suspected cancer pathway to your patients, if you could, please. Brilliant. So we'll move on now to the next bit. And so, okay, so this is a little bit about what's been happening as an update. So generally speaking, so this is over the entire of West London, so not specific just to Northwest, so also including Southwest London. We've talked about the different trusts that we're live at and across the different sites as well. And we've had a decent number of referrals that have come in the period of 2021. Now, as we move into 2022, the referral numbers have continued to increase as we are expanding the service and we're diagnosing more and more cancers. Within our pathway group, we've developed some key clinical guidelines for common presentations. We talked a little bit about the presentations earlier that come in very much through our service. And we've completed an economic evaluation that was done independently, that was commissioned by RM partners, but covered by Frontier Economics. And interestingly, the model is suggestive of significant cost savings and is being presented to the relevant CCG and ICS in order to consider how we kind of map this out long term. As a group, with every about 4 times a year, we'll catch up and we'll talk about interesting case studies, and we've got a couple of case studies later on that we've already presented as a group, and we have our own kind of little forums where we catch up between the GPs and the nurses. You may have heard about the Grail study, which is not specific to rapid diagnostic centres, but it was looking at a blood test, looking at circulating DNA, and which are leaking from tumours really, and it's the MCED tests, and where we were looking at detecting cancer signals earlier within the blood. And so we, within West London, Chelsea Westminster was the one site to kind of have this, and we included patients from the RDC. So we were very happy to contribute to some of these bits and pieces. And we're linked in. I guess it's also important to say that we try to be integrated within the trust and other pathways, and we try not to work as silo, because the whole purpose of the RDC, the way I see it, is it only really functions best when we have the right network available. Excellent. Can we move to the next slide, please? So here's some data. We asked about data earlier on, and so this data has been taken from the Chelsea Westminster Trust, because this is what I had to hand. And so this is from December 2020 to January 21, and it looks at very briefly the number of referrals that came through each site. West Middlesex was just opened slightly later and at the time just covered a smaller population, but now covers more, which kind of explains the discrepancy in numbers coming through. But what you can see is actually what's the conversion rate is still pretty significant. You will probably know that your traditional 2 equal weight site-specific pathways have a conversion rate of anywhere between 2 and 5%. So for us, sitting at an 8% cancer conversion rate probably means that we're not seeing enough people, but it also means that we are certainly seeing patients with cancer and the right people are coming in. So there is a real balance there. And if we break it down within the cancers that were diagnosed, you can see that they come, so that there are various different primaries. Now, these patients were not referred down a suspected lung, lower GI, heme, whatever pathway. They came to us first, and that's because their presentation was vague and it was non-site specific, and it wasn't quite clear that it was that primary. And so once we've diagnosed that cancer, we've passed it on to that relevant MDT, and that patient has gone on to be under that specialist moving forward. So I think that's quite interesting data there. So we've got a few questions, so I might just pause here while we go through these questions. Baldi, please do jump in. There's a question about how strict are we about fit tests within 4 weeks, checking another fit introduces delays. Yes, we do appreciate that, and I think we are. If somebody's got a stonking neck mass and you're worried about a cancer, you need to get them in. Obviously, like, the fit is not the most relevant thing, but I think what we do find is sometimes we incur diagnostic delays here on this side if we don't have the fit. And what's important about the fit, as you know, is it helps risk stratify. And if the fit is raised, so I've just seen a patient this morning with a history of colorectal cancer, and the fit was done, but it hadn't been done before the referral. And she came into us this morning with, I think there was the there was some non-specific pain, but her fit was, the result you could see was 500. And so if she went to the lower GI pathway straight away, then it would have been a better service for that patient. But they've come to us and now we've had to move it on. So I think what we think about is, in context, it is very helpful. But if you think in certain cases it will introduce a delay and you don't think it's appropriate, then maybe just put that in the form so we know. And I think that,
Yeah.
Baldi, what do you think?
No, I agree actually, because there have been times where we've seen patients where we've started off the diagnostic pathway and then the fits come in and it's raised. It takes us longer to then coordinate the colonoscopy, whereas it would be better served going down a 2-week wait pathway for colorectal. So that's generally why. But as Ab said, if you've got a neck mass or there's something else that's really obvious, just you can absolutely put it in the referral.
And thank you. Rachel, did you want to come in? Your hand went up and then went back down.
The second one was on for PSA. Do you still want this if a man is young with no relevant symptoms or family history? So I do a PSA on men when they come into clinic, because this is a suspected cancer clinic. So a PSA is something that I would be looking at. Obviously, I would correlate it with symptoms as well, but I do a PSA. What are your thoughts, Albs?
Yeah, I think so. I think in the context of vague symptoms, if somebody's coming with weight loss, general fatigue, low appetite, and you're worried about them in a man, a PSA is a helpful test, because they may have some non-specific pain and they may have metastatic prostate cancer, and a PSA is just incredibly helpful. I saw a chap 3 weeks ago, and he was 80-something years old, very fit and well, and his only complaint was, I just don't feel right. I used to be able to, at the age of 80, was lifting like 15-kilo dumbbells, which I thought was amazing. And then he said, well, I can't do it anymore. And my GP's a bit worried, and we did a PSA. It was like 600, and so it's interesting how these things can happen. And he's got metastatic prostate cancer, so I think I would do it.
And can we do a CPK test as LDH has been added? I'm a bit confused by that.
Yeah, not entirely sure what we mean.
No.
Maybe we can catch up offline. So I'll put that in my I'll put my email address there, and we can chat about that. And the final question is, if no cancer is found and an onward referral for further specialist investigation is recommended, will this be done directly by us? Okay, yeah, very good question. So I think here it depends on a couple of things. One is this patient unwell, right? Is it unwell? Does it warrant an urgent kind of secondary care referral? Then yes, absolutely, we will do it in, and that's within the national specification of RDCs. If there is sometimes this patient will need an MSK input, a physio, a dietitian, this, that, the other, better served within the community, and your local GPs working in the RDC will have a flavour of what's happening in the community, and so we'll be able to advise that. So yeah, so it will really be patient specific. Baldi?
I agree. Often we do try, and if we can plug them into secondary care, we do try and do it from the clinics, but sometimes the pathway is much easier for the GP to do, and I think the same with MSK, dietitian. It's all community-based GPs.
Brilliant. Okay, let's move on then. So, right, we're on to some case studies in good time. Well, I'm going to talk about a patient who I saw, I think it was about last year. So she was 56 years old, and she generally was incredibly fit and well, never drank, never smoked, and she had some very innocent kind of past medical history, nothing that concerning. She went to her GP because she had a generally acute and worsening tummy discomfort. She felt a bit more bloated, and she felt a bit of reflux, and she started to lose weight. And that was happening over roughly around about 3 to 4 weeks. And she also noticed that when she was generally somebody who could go for regular runs, and she wasn't able to do that anymore. So she was a bit more short of breath on exertion. So there is the examination findings there, which is actually what I found when I saw her. But if generally speaking, if you see these examination findings, what we want to do is just a little poll. What would you want to do for this patient? So we've got 6 options, and Sophie, Stevie, has put that poll in the chat box, and maybe it's appearing on your screen. So it'd be great if you could have a look at the chat box and just think, would you order bloods and X-ray, send this patient to A&E right now, refer lung, refer heme, upper GI, or watch and wait, assuming that there's no RDC available at this stage. And so just to kind of recap while you're both all clicking there, this was somebody who's got kind of general symptoms, which is mainly upper GI, a bit of weight loss and shortness of breath. And she's when I examined her, she looked a bit pale, and there wasn't a huge amount of air entry in the left side on the left base. So we've got some responses coming through. Bloods and a chest X-ray. X-ray I've written, so chest X-ray I meant. Heme 2-week wait, there's one, and a couple saying upper GI. And vast majority have clicked order bloods and an X-ray. I think that's very sensible as a first step. And let's move on. And I think we've got some information of what was done next. So at this stage, this patient had some bloods done, and that was done in the community, part of them, and a fit test. And then they came to me, and the examination findings is what I found. And these were her bloods. So she had what appeared to be an inflammatory anemia in her blood. So her ESR and CRP were raised, and then she was anemic. But her serum paraprotein and Bence-Jones protein were negative, and so and her fit was normal. So she had a lot of upper GI symptoms, and but also this picture of an inflammatory anemia and a suspected pleural effusion on examination as well. And she wasn't well. So we organised a few things. We organised a bit more bloods, an upper GI endoscopy, and cross-sectional imaging, a CT scan. And if we go to the next slide, it's just some screenshots taken of her CT scan. And what you can see here is that she's got a near collapse of one of her lungs, which was kind of pretty much encased in fluid, and lymphadenopathy above and below the diaphragm, and a lot of organ infiltration here as well. And so what we did was, for this patient, we did a pleural tap within the AEC department, and that fluid was sent not only for culture but also for flow cytometry. And she had a large axillary lymph node. You might be able to see it on that image on the right hand side, and that was sent for a core biopsy. The fluid, as well as the core biopsy of the lymph node, came back showing a diffuse large B-cell lymphoma, and so she was diagnosed with a hematological malignancy. And for that patient was then passed on to the hematology MDT and is currently on treatment. So what we have here is actually a very interesting case, and I think what it demonstrates here is that this patient had general vague symptoms, a bit of upper GI, a bit of respiratory, bloods weren't quite right. It's very difficult to pinpoint, but ended up having a heme cancer. And you could have easily sent this patient to various different pathways, done a few bits and pieces within the community, and been a bit stuck with, actually, well, what do I do? I am worried about this patient. She may have ended up in A&E. And so the RDC functioned quite well in order to be able to help this patient. Although we couldn't diagnose her at an earlier stage, we were able to improve the pathway to diagnosis.
I think that's what it beautifully highlights, doesn't it, Abs? This patient could have ended up in A&E, I think, given it a little bit longer, and we would have had that A&E diagnosis, wouldn't we? Which is what we're trying to prevent, aren't we?
Yeah, absolutely. So I think we've got the next case. That's yours, Baltic, right?
Yes. So this is a lady that we saw very recently, actually. She's a 52-year-old lady, non-smoker, no alcohol. She had a performance status of 0, but when she came in, she had performance status of 1. She just feels a little bit off. She's got fatigue, extreme fatigue, and nausea, getting full earlier, slight loss of appetite, minimal weight loss, not much, and a little bit of vague abdominal pain. Extreme fatigue twice, in fact, and some night sweats as well. Now, the interesting thing about her was that she was diagnosed with a right-sided breast cancer in 2019, and she had a wide local excision and a sentinel node biopsy, and she had radiotherapy, and she was on tamoxifen for 10 years. Now, she had been seen in the breast clinic the day before she came in for her ADOC assessment with us. Her background history is there. So she's got diabetes, hypothyroid, fibromyalgia, ischemic heart disease. She's got things that you could pin those vague symptoms onto, I would think. But when I examined her, the only thing I found was a little bit of right inguinal lymphadenopathy, and that was it. So if you saw this patient, we're going to put a poll up now. What would you do? Would you order bloods and an ultrasound? Oh, it's moved from my screen, bear with me. Send to A&E, refer to the 2-week wait breast team, refer to haematology. Now, I know I haven't given you her bloods yet. Refer to gastro. She's got a few symptoms, hasn't she? Or would you just watch and wait? I'll give you a few minutes. Because this, I think, definitely with this patient is somebody that you could see over and over again, could present a couple of times with the fatigue. And it was the fatigue that was interesting with her because it was a 6-week short history of fatigue. Okay, I'm looking at this. Yes, quite sensibly. Order bloods and ultrasound. Yes, that's exactly what I would be doing in general practice as well. And interestingly, someone has put 2-week wait breast. Good. Right, I'm going to move on. Next slide, please. So her bloods were normal. Haematinics were all fine. Her myeloma screen was negative. Her CA125 was negative and her FIT was negative as well, it's less than 4. We decided to do a CT chest, abdomen and pelvis because there was just something not quite right about how she was presenting. And she was found to have bony sclerosis in T8 and T10, suspicious for metastatic disease. So I've put a little MRI picture there of her spine. Next slide, please. So she was discussed at the breast MDT within the week of having the CT scan done. We then saw her in the afternoon. She was discussed at breast MDT in the morning. We saw her in the afternoon because this was likely a recurrence of her breast cancer. Broke the bad news on the same day, and then the following day she was seen in the breast oncology clinic for a forward plan onwards and for treatment. She was informed of her CT findings. They organised a bone scan and a biopsy and followed her up with the results, and she's on treatment at the moment. So the total pathway time for her from referral to diagnosis was 15 days. That's, I think, as rapid as rapid diagnostic centres get. So she's still alive and she's having treatment. Next slide, please.
Brilliant, thank you, Bardeep. So what I want to do next is just briefly talk about raised platelets in the context of some of the concern that I hear within primary care and from my colleagues and some of the studies and information that has been released within the last few years. And so you may have already heard about this and you may be completely okay with this information, but just as a quick recap, there was a publication within the British Journal of General Practice where we had a look at medical records for patients within this country, and looking at whether there was a relevance of thrombocytosis within primary care in the context of cancer. So when we say thrombocytosis, the cutoff was a serum platelet count of over 400, and what was found was that there was an increased incidence of solid, so non-hematological cancers in patients over the age of 40. Where there was a new raised platelet count over the threshold of 400, and most of these were either lung or colorectal cancers. And I guess what was scary was that they had no other symptoms that were suggestive of cancer, and I think that's what sparked a lot of concern when this came out. Next slide, please. The NG12 guidelines have kind of shifted to reflect some of these issues, and that we should consider the legacy cancers in patients with a new raised platelet count. So consider, and that doesn't mean that they will have one of these cancers, but it is something that we should consider. So LEGO meaning lung, endometrial, gastroesophageal, and colorectal. Next slide, please. So I think probably within primary care, if I'm sat within primary care and I have a new finding of raised platelets, the things I just need to consider are there any red flags for legacy cancer, and all of the other symptoms and other causes. And most of the time the raised platelet count will be through iron deficiencies or inflammatory conditions, but it also can be with medications and even other chronic diseases. So patients with COPD will have a chronic raised platelet count at times, and even things like celiac disease and pregnancy can. So it's important to kind of just think about these other things in your history taking. Next slide, please. So what I tend to do is just look at the historic platelet count. I will do some blood tests for these patients, and that will have a look at kind of iron deficiencies, a full haematinics, and inflammatory markers. We talked about kind of tumour markers, so PSA for men and CA125 for women, because within this study, both prostate and ovarian cancers were found. And if you've not done a celiac screen before, that's helpful to do so. When we think about lung, chest x-ray is helpful, and we think about colorectal, a quantitative fit test. So a fit test is very, very helpful. Part of also the NG12 guidelines will be when we think about endometrial cancers, a transvaginal ultrasound is helpful for women that are over the age of 55 and have got either frank hematuria or unexplained discharge. If the platelets are very high, so over 1,000, talk to heme, or if they're over 600 and they've got some thrombosis or abnormal bleeding or hematological symptoms, have a chat with heme. Now, if you've done some of these things and you're still not sure and you're worried about a cancer, please send it to us at the RDC if you're worried about a cancer. Good.
Abs, can I just pause there for us? There's a question from Sima. Would a raised isolated ferritin with HB raised but normal hematocrit be appropriate for a referral? Heme A&G states monitor but have vague concern that something else is going on. Does an isolated raised ferritin over 2,000 warrant an RDC referral? I think with a raised ferritin, my first thoughts would be a liver screen, liver ultrasound, possible hemochromatosis. They're the first things that pop up for me. And has that happened? What are your thoughts, Abs?
Yeah, I think so. I think lots of things can cause raised ferritin, and similarly with raised B12. And the odd study here and there will suggest that there can be times where we will diagnose a cancer. And so I think let's think about the liver stuff first. But if you are worried about malignancy and you're not getting anywhere, ping it to us. We have our network of clinicians, and we're very happy to see patients as well. So absolutely fine. And then Rakshan's put in a comment, if no symptoms but persistent elevated platelets justify a referral to the RDC. So again, there is in the studies, some of these patients do have symptoms, and I think if you've explored all of the other filter tests that's on the screen right now, and you're worried about a new rise platelet count of 100 where there is no other explanation from the other comorbidities and the other benign conditions that we talked about, yeah, if you're worried, send it to us to see a patient. Okay. So finally, really, there is some kind of the protocols and guidance that we talked about that we've put together within the RDC. They're freely available off our the RM Partners website, and so you can have a look at these if you just put in RM Partners Rapid Diagnostic Centre. It's there, and the links will be provided when we circulate the slides. So it's all there, and it's just a little bit of how we tend to approach things at a genuine kind of basic grassroots level. And that was put together by our pathway group through different clinical specialties that were involved, radiology, hematology as examples as well. Excellent. Next slide, please. So I would like anybody here from an RDC to jump in if there's anything that you would like people to take home. But I think probably the main thing that I want to say is that we are encouraging referrals to the Rapid Diagnostic Centre. If you're worried about cancer as a clinician, if a patient has non-site specific symptoms, we are there to help. You can find us on ERS, and what we try and do is we will do our best to do a holistic approach of the investigation of these non-site specific symptoms to see if we're dealing with a cancer or not. And the information should be cascaded through your borough leads and to support practices and PCNs in order to do this. And patients with vague symptoms can sometimes be quite unwell, and they can indicate cancer. And we talked right at the beginning about issues about experiencing longer diagnostic intervals and presenting within the emergency department. So that's exactly what we want to avoid. Baldeep, is there anything you'd like to add?
I think that's you've touched on everything that I think of, especially leading the RDC here at West Mid. Filter function tests, please. Just the basic filter function tests would be brilliant, just so they come with that referral. They're probably the most important things. And actually, I hope it came across. We see people really quickly. We often see people within 5 days. So we can see people in quite quickly if you're worried about them being unwell.
And there's one more question from Simon about are the referral forms available on See the Signs. Yet we've had a chat with See the Signs team and we've sent them all of our referral forms, so it should absolutely be there, and your local RDC form should be available wherever you are. If there are any problems, please do flag it with your borough cancer lead, and that can be escalated appropriately. Brilliant. So I think that kind of brings us back, brings us to the end and the close. I hope what we've done is we've demonstrated the benefits of the RDC and what patient cohort that we try and serve. If you have a couple of minutes, please do use the survey link, which Steve will be putting in the chat box. Sophie's done it. Amazing. Thank you. And do send us any feedback through there or elsewhere. The next webinar will be on gynae cancers, and that's going to be towards the end of June. And so we really look forward to seeing you there. There is a hand that's come up. So Samira, we've got a hand up for you before we close.
Yes. Hiya, hi Doc. Thank you so much for the teaching. This is really great. Keep it coming. Just the first scenario, I'm really sorry, I missed the answer. What was the answer for the first one?
So within the first case study, I think we had a patient who had a hematological malignancy, which was a diffuse large B-cell lymphoma. I think what we were trying to demonstrate here is that the patient had different symptoms from different sites, and bloods were a little bit abnormal. And if you were worried about this patient that didn't fit a heme pathway, you sent it to an RDC, and we can work them up quite quickly. Okay,
thank you so much for your help. Thank you.
Not at all. Not at all.
Just on the back of that, Abs, I just wanted to say that sometimes your blood tests are all normal, but you still have those symptoms, and the vague symptoms are there. We still see those patients. Just, you don't have to have abnormal blood tests, even if they're normal.
You mean do a 2-week referral? You mean just do it? Just do the referral if you have concerns, yeah?
Yeah, if you've got a patient with vague symptoms that you can't account for, but the blood tests are, we often see a lot of people with normal blood tests as well. But so it's just, yeah, absolutely send them in if you're unsure.
God bless you. Thank you. Cheers, dear. Thank you.
Thank you, everybody. We've got one more hand. We've got 2 minutes, so I think it's Dr. Garcher.
Yes, can you hear me now? Hello, can you hear me all right?
Yes, we can.
We can.
Thanks very much. Just a quickie thing, really. Could RM partners looking at supporting PCNs where there may be sort of what you might call getting this on the ground, because those are kind of classical cases which we'd refer, and probably I would have disagreed with your management. If somebody with a pleural effusion, I would send them to A&E, because I think waiting for something else or making sure that I'm absolutely sure that it's a pleural effusion, I would probably err on side of caution. And I picked up an asthmatic 14-year-old with leukemia whose asthma wasn't getting worse, with the clinical signs of a pleural effusion, and then when they drained it, that was it. So one of those sort of, shall we say, surprising diagnoses. And we also had a lady recently, 6 months postpartum with twins, with GI and liver secondaries, you know, the bolts from the blue, which sometimes come up. And I think what I'm suggesting here might be is, for you, are you able to consider providing a service where, you know, where we can discuss these kind of things, or the learning for particular practices or practitioners, where sometimes there can be emotive things for the practice themselves, where you get somebody like this and patients obviously get a degree of, shall I say, deflation, and even if you've known the person for quite a few years, that these things tend to happen. So I think that looking at a sort of kind of PCN basis, and to see one on the individual side, providing support for practitioners, because I think practitioners sometimes find it difficult to be able to raise their head behind the parapet and saying, look, I think I may have had an issue. Is there something that I could have done better? That's one. And the other one's on a PCN. If there are particular things, I know we did the cancer survey, but I think that the sample size might have been too small to really apply for some learning. And I think sometimes here in Northwest London, when we have a lot of flux of people going in and out and moving from GP surgeries and then moving around, to saying, are we able to follow up the patients well and therefore get the learning that we should do on the ground? So I know I've said a lot of things, but hopefully you can understand where I'm coming from.
Thank you, Dr. Gotcha. Yeah, absolutely. And I think probably number one, my apologies that the examination findings for this case were those that came through that I saw and not what the GP did. But secondly, to your points, what I'll do is we'll link in with the Hounslow Borough Lead to try and address some of the concerns and make a plan, generally speaking, for primary care and cancer. I'm going to have to stop now. Any other questions, please do email us. And then very happy to take things through. It's 2 o'clock and I'm sure everybody needs to get back to clinic, but thank you very much. And thank you for coming, and I hope we've learned something about RDCs today.
Thank you very much.
And,
thank you, everyone.
And please do more teaching. It's amazing. Thank you.